Again, welcome everyone to our webinar today on Write It Right, Purposeful and Defensible Documentation in Senior Living, focusing on falls. So we'll just start with a couple of housekeeping items. Everyone's audio has been turned off for today's session. So if anybody has any questions at any time, you're welcome to submit those through the Q&A feature. We will hold the questions till the end and promise to get through as many as we can. But any questions that we don't get to, we will circle back and promise to follow up after the webinar. Today's webinar is being recorded and will be sent out to all attendees after its completion. Today's webinar is about 1 hour long and offers a 1 hour CE through NAB for nursing home administrators. So at the end of the session, all attendees will receive a questionnaire to solicit feedback as well as your NAB number. We will report your attendance to the NAB within the required 30 days. Next slide. So just for your consideration here, the information recommendations from this webinar are really from a risk management perspective. And, we're not attorneys, so this should not be considered legal advice. The examples that we're using for documentation are not necessarily comprehensive and should not be intended to be taken word for word. Just a little bit about who we are. So we are at K&B, or Care Agents by K&B. We provide liability insurance coverage for long-term care organizations, including nursing homes, assisted living, CCRCs, memory care communities. We've teamed up with some innovative technology partners to focus on fall reduction and wound management, which really rounds out our program with our comprehensive risk services and aggressive claims management. Next slide. I'll just introduce myself and then I will pass it over to Shannon. She can introduce herself. Um, so I started in the social service department in skilled care, became a nursing home administrator after a few years. I actually have spent the last 10 years in risk management, really focused on all supporting long-term care and senior living organizations and communities. So Shannon, I will pass it to you.
Okay, thank you. So I'm Shannon. My background is in occupational therapy, and I spent about 8 years in a clinical role in skilled nursing and assisted living, and then 5 years in senior living risk management before joining Care Agents earlier this year. So here's today's learning objectives. We're going to identify best practices for accurately documenting resident fall-related information in the medical record. We will learn to apply defensible documentation techniques to clearly and objectively record fall events, and we're going to analyze some case examples to illustrate how fall response and documentation practices can influence liability. So here's our first one. So we're going to identify fall-related documentation best practices. So let's start with some statistics concerning documentation. These statistics are current and they come from a national 8-month survey of over 9,000 US nurses working in hospitals, surgery centers, physician practices, and outpatient facilities. Approximately 40% of a nurse's shift is spent documenting. Almost 70% of nurses say documentation burden and poor EHR usability are major contributors to job dissatisfaction and a desire to leave. 2 in 3 nurses under the age of 40 say the EHR experience is a top 3 factor when evaluating new employers. 80% of nurses want to work for an employer with a more nurse-friendly EHR, and 88% of new nurses say they have little to no experience with their employer's EHR. So new nurses are certainly spending more time in the EHR, not just documenting, but also searching for clinical information and adjusting to the workflow that their EHR requires. These are the best practices we're going to discuss today, and we are applying them to falls. So you will see all the examples pertain to falls. It could be daily documentation or post-fall documentation. These practices would apply to both. A policy for documentation should be established to guide nurses on the principles and procedures of documentation. The policy should state your purpose and define some terminology. Your documentation principles will cover a range of details, but some of the key principles are for nurses to deliver and document care that is within their scope of licensure, only use approved abbreviations, and if they are using a copy and paste or template function, that they are reviewing and editing before electronically signing. Outline your procedures, any documentation methods, maybe charting by exception, and how that is applied at your facility. Documentation needs to reflect when care is actually provided and not at the time of documentation. And the policy needs guidance on late entries, corrections, and addendums, including the time frame of each. When is a late entry acceptable? How long after the care is provided is it considered a late entry? When is an addendum needed? And how should resident and family education be documented? Should the documentation include, topics covered, the response and the retention? And as with other policies, you want to review and update them as needed, at least every 2 years. Make sure the latest revision date is on the policy. And a good risk management practice is to archive your outdated policies. Documentation in the residence record needs to be objective. Objective documentation, it's factual, it's measurable, it's observable information that can be verified by others. Objectivity requires you to eliminate personal interpretation or bias. And an easy way to do this is to stick to what you saw, what you heard, what you physically touched, what you smelled, what you measured. So remember to follow your senses to remain objective. And these are some examples of objective documentation. So first, a resident may have fallen and hit his head. This is not factual and it's an assumption. So an improvement is to say, the resident stated his legs gave out when attempting to sit on toilet and he hit the back of his head on the toilet seat. The second one, the resident needs a bath. This is subjective. Why do you think the resident needs a bath? What did you observe? The resident's hair is oily and smells of body odor. Third, the resident looked more weak than usual. This is subjective. How does the resident look more weak? What did you observe? The resident was leaning toward the left side. And if you catch yourself incorporating an emotional response in the chart, that note is probably not as objective as it should be. I think it's also helpful to understand what objectivity is not. So objective documentation is not subjective. You should avoid assumptions or personal opinions. Avoid statements like the resident's doing well or appears to be and is stable. And avoid describing the resident as confused or anxious. These are assumptions and they're not based on facts. They're not based on your senses. An example is the resident found on floor after falling. So this is an assumption if you did not witness the fall. Jousting is a direct disagreement with any other health professional or caregiver in the medical record, or a calling out of their error or omission. So for example, previous nurse did not communicate increased fall risk. It's not helpful to the incident, to the fall, so it's not appropriate for the medical record. Discriminatory documentation can be toward the resident or the family, but you want to avoid statements that can be considered discriminatory. An example is documenting that the resident was acting crazy. So this is not only a subjective assumption, but it's an inappropriate description of the resident. What did you observe through your senses? The resident was flailing their arms in the air and they were yelling this, that, and the other thing. So this offers observations and facts about the incident, and it's helpful in determining a root cause to the fall. And objective documentation is not judgmental. For example, the resident is too stubborn to use their call light and got out without assistance. So we can improve this to maybe the resident did not use call light to ask for assistance and got up on their own. So objective documentation, it's factual, it's based on observations, and it doesn't point a finger at the resident, the family, other staff members, or even the facility itself. Accuracy of documentation is our second best practice. Accuracy can certainly be a contributing factor in liability claims. To document accurately, you should be precise. For example, a small cut on forehead is subjective, it's not specific, and a small is not really measurable. Maybe we can improve this by saying a 1-inch laceration on forehead near the left temple. And accuracy depends on matching the resident's person, their status, their history It cannot conflict with any other factor. For example, if you documented something about a resident's left foot, but the resident's left leg is amputated, that is conflicting and therefore it's inaccurate. When standardized forms or templates are used, it's important to address every action on the form. So if the indication or the action is not relevant to the resident, then there should be a choice for NA, for not applicable. A blank statement, a blank in a standardized form may communicate, I didn't ask, as opposed to, it's not applicable to this resident or this circumstance. To enhance accuracy, templates should be representative of your protocols. If the template has areas that don't apply to the protocol or to what needs to be assessed, rather than having the nurse fill in information that isn't needed or is duplicative, or have them just leave it blank, look at what you can remove or reword or rearrange. And copy and paste. It's an efficiency feature of EHRs and it has its place in documentation. One study found that among efficiency variables like chart search or smart phrases, the only variable independently associated with decreased reporting of burnout was a clinician's use of copy and paste. And another study found 82% of text in inpatient progress notes were copies or generated by a template. So these studies tell us that this function is being used frequently and that clinicians really like it. The important thing we want to monitor is how it's being used. So it may be an efficient feature and it's going to allow time for nurses to spend more time with their residents, but documentation accuracy also should not decline when employing copy and paste. So you want to train your staff to review and edit their notes, copy and paste or not, really, but before they complete and sign the note. And an example of copy and paste that is not accurate is copying over information that is outdated. So your note says the resident is doing well on Lasix, but the resident is no longer on Lasix. And copy and paste can also facilitate the inclusion of information that may have been omitted, like saying the physiatrist will follow up on the new brace. So this is informative, and it's letting the reader know that it is planned, but has not yet occurred. When doing fall risk assessments, which should be done on admission, post-fall, quarterly, and with significant change, we should be documenting changes to baseline, and you may want to note any quantitative changes to a score and which risk factors have changed compared to baseline. And fall risk scoring is often embedded in the EHR, which makes it easier. When there is a change, the assessment results should be communicated. Maybe your facility uses an SBAR tool to communicate changes, and communication should be documented. Who did you call and what did you discuss? And when there is a change in a risk assessment, there should be a change in intervention. This is a best practice and a defensible practice when it's documented. And here's a good reminder to look at your fall risk assessments and make sure it aligns with your documentation practices. I know many organizations use the fall risk assessment templates in point-click care or whichever EHR you're using, but you should look at what it's asking. Is it evidence-based? Is it based on a standardized fall risk assessment like the Stratify or the FRAT? Is it addressing risk factors specific to your resident population? And ask your nurses if they like it. Is there information that is not needed, or they're just leaving it blank, or is it taking too much time to complete, so they're just not completing it? Change the template, change the assessment to what will work for your nurses and what's needed to effectively assess your residents. Timeliness. The longer the gap between care and documentation, the greater the risk of forgetting details or misrepresenting events. Notes written immediately after care are more likely to reflect the actual interventions, observations, and the resident's response. Real-time charting allows you to stay focused on the present rather than mentally replaying your entire shift to reconstruct events. One study found that nurses who documented in real time reported less errors and less cognitive overload than those who charted at the end of their shift. And efficient documentation practices are linked to lower rates of burnout and higher job satisfaction. Timeliness of documentation also impacts resident safety. If you delay documenting a resident's deteriorating condition, vital information might be missed by the next team member, potentially leading to delayed interventions. And when you chart immediately after care, you ensure that all healthcare team members have access to the most current resident information. And this reduces the risk of miscommunication and can help improve coordination of care. And when it comes to pre-charting, which is charting before care is actually delivered, don't do it, never do it. It's illegal, it's fraud, just don't do it. That's all we have to say about that. A process we recommend that can really help to gather facts in a timely manner after a fall is a post-fall huddle. So the post-fall huddle serves as an interdisciplinary and QAPI process aimed at gathering information immediately after a fall to reduce future fall risks. Huddles can facilitate timely collaborations of your frontline staff and any witnesses to discuss and document the facts and the observations surrounding a fall. And conducting the huddle promptly ensures that precise reporting and can preserve crucial information that could otherwise be lost. Post-fall huddles have really become a best practice, and we put together a post-fall huddle tool for our clients to tailor to their own practices. And using a tool for your post-fall huddle can help make sure you're asking the right questions and gathering all the details that will help identify contributing factors and root causes. Another best practice for documentation is to use or avoid certain verbiage and terminology. So there should be guidance on which abbreviations are approved to use in the medical record. Direct quotes should be used when possible, particularly when describing the chief complaint. Using words like unintentionally, inadvertently, and unexpectedly should be avoided, as it can come across as something bad has happened. Words like appeared, apparently, or seems to be are not specific and can cast doubt on what is written. And saying a resident feels good or looks good, these just aren't specific and they can mean different things to different people. Consistency of all the best practices is another best practice. So consistent documentation provides consistent communication to other clinicians, and practice makes perfect, right? Consistently applying best practices makes them easier to do over time. So here are some examples of what we have covered so far. Being specific and quantifiable. Rather than saying left hip appears fine, it needs to be specific. So something like left hip negative for bruising, swelling, or deformity, 0 out of 10 pain, range of motion within normal limits. This is specific and it's measurable. Be concise. The family was called and the daughter was told that her mother was noted to have a change in her mental status and was more confused than normal. This is just overly worded. A concise way to say this is notified resident's daughter regarding a change in mental status. Be thorough. An example of this is to have a resident demonstrate safe use of a wheelchair after providing education and documenting what actually occurred, rather than just writing fall risk education was provided. And lastly, be precise. Even when describing the resident's status from a less clinical lens, you observe the resident walk further today. This can be helpful to communicate, but can be more precise. The resident ambulated 100 feet with rolling walker and standby assist. So now you have a distance and an assistance level. So if you aren't the writer, but the reader of that note, you now know the current mobility status and can apply it to your care. The last best practice is for documentation to be complete. If the note is lacking specifics, measures, or responses, it can raise liability concerns because it can result in accusations of negligence. For documentation to be complete, it needs to be legible. Clinical language may vary slightly, but it should also be legible to any clinician reading the chart and be clear of what care was provided. Critical resident information needs to be recorded. Assessment details or critical measures and any missing data will make the record incomplete. After a fall, documenting neurochecks is critical. So it's critical to recognizing and treating a potentially life-threatening condition. And if a check is not documented and there is resident harm, that can just open up a can of worms. Complete documentation avoids vague or ambiguous statements. When documentation is not specific or precise, it can leave the reader of the note questioning the information or the care provided. Ambiguous documentation is the same. The reader should not be confused by your documentation. For example, the resident was assessed and put back to bed. This doesn't tell the full story and what assessment was done. Charting by exception can mean something different to different people, but by exception or not, vital care assessments and information needs to be documented. It's a form of communication to other clinicians. After a fall, the resident's physician and family should be notified, and those notifications need to be documented for completeness. When you call the physician, note when you called, who you spoke to, or who you left a message with, their response, and any new orders. And also post-fall monitoring. You want to document interventions and their effectiveness and any results of testing or information from the hospital after transfer even. This documentation is needed for completeness. The S bar is a good way to frame and communicate critical elements and changes, especially when documenting conversations with the physician. So this is just a summarized S bar with key elements for a resident fall. The bolded information is what is filled in, and the leading statements are included in the tool to guide what should be documented. The situation is that Mrs. Green fell in her room. Here are her vital signs. I assess the resident personally and am concerned about her pain and her guarding of her left elbow. Her current mental status is alert and oriented ×2, which is her baseline. Her skin is without lacerations or contusions. The left elbow pain is new and it's different than her baseline. I think the problem is a left elbow injury. And I recommend that you order a left elbow x-ray and as needed pain medication. So the SBAR is still really a best practice tool for communication. Documenting in this framework can help ensure the documentation is specific, measurable, thorough, accurate, complete, and also timely and concise, as the use of this standardized tool will guide you through what information is needed. It's important to consider the barriers to implementing these best practices for documentation and address any that are identified within your system. There are technical barriers like slow EHR platforms or frequent login issues. One study also found that almost half of the care staff on one unit reported there was an insufficient amount of computers to allow for timely documentation. So access can be a barrier as well. There are organizational barriers like lack of clear documentation policies or training, redundant documentation requirements, and maybe cultural norms that undervalue documentation. And there are staff level barriers like fatigue and burnout affecting attention to detail in documentation, poor communication among team members, and insecurity or limited knowledge about proper documentation. So it's important to identify these barriers and address them through a systems thinking approach. So there's our first objective, and here are some of the key recommendations. Start with a comprehensive policy for documentation that's going to guide your staff on documentation practices. Staff education on documentation should start upon hire and continue throughout the year. Documentation should be objective, consistent, accurate, timely, and complete. When it comes to a fall, this information is critical to identifying any contributing factors or root causes. Establish a post-fall huddle to help gather facts that are objective, accurate, and timely. And chart as you go. Try to create a routine that's going to help ensure documentation is timely. And this can help make documentation a habit rather than a task. And regardless of method or policy, documentation should always ensure assessments capture essential information that impacts care decisions. Okay, let's move to our second objective. So we discussed documentation best practices. Let's look at how to apply defensible documentation techniques to clearly and objectively record fall events. When a resident falls, is harmed, and a claim is filed, the documentation can make or break a case. It's the first question from the defense team. How does the documentation look? It can be the best or the only evidence for defense. The care decisions and practice can be great, but the documentation can be poor, and that can hurt a case. For documentation to be defensible, it must tell a story, and it's a shared responsibility among the care team. We all need to apply best practices consistently and for the documentation to be defensible. After a fall claim, the documentation will come into question and it will be used as evidence. The documentation policy needs to guide staff on best practices and organization-specific practices. The policy will also come into question. And let's not forget that good documentation can help prevent resident harm. Those specifics, the measures, the accuracy, the timeliness, it all impacts the care you provide to the resident every day. So it's a critical practice from every aspect. Defensive documentation is many things. This list is not comprehensive. I will let you read the list here, but defensible documentation clearly explains the clinical decision-making behind care provided. It's not subjective and it's not conclusive. It doesn't exceed scope of practice. And documentation includes measurable observations and demonstrates medical necessity and the standard of care. It aligns with regulatory expectations and evidence-based practice, and it can withstand legal and peer scrutiny. Defensibility can be challenging when documentation is the things on the right. So it's not aligned with the resident's care plan or preferences. It's inconsistent or it's contradictory. It's emotional or it's subjective. There's delayed entries without justification, or there are missing key elements. So many of these practices are from our first objective. If you follow best practices, when you document, it will be more defensible. So on the occasion that a resident's record must be amended, the documentation policies must outline who, when, and how records may be amended. Policies and procedures for amendments must be in place to ensure the integrity of the information contained in the record for resident safety, the business record, and the legal record of the organization. Once a document has a final sign-off, the only way to correct or revise documentation is to provide an addendum. The organization should have a specific policy and procedure addressing how addendums are made in the health record. The addendum should be timely and provide the reason for the additional information being added to the record. And the EHR may let you backdate, but the current date and time will be stamped on that documentation. So it's really important to define in your policy when a note is considered a late entry and when it requires an addendum. And even if the function existed, nothing should be deleted from the record. The original version should always remain a part of the EHR. There is an audit trail and all the data is there with the timestamps. You know, when you access the record, how long were you in the record, all that data exists. And if there are any red flags, it can make documentation less defensible. So documentation that is inconsistent or includes discrepancies can be less defensible. And examples of this is when notes don't match the resident's status. The documentation says that the resident was flailing all extremities and caused them to slide out of the sling during a lift transfer. But the resident's a quadriplegic, so that is a bit conflicting. Another example is when the notes don't match a previous note. First note says, pupil was not reactive during the neuro check. And the other note said the pupil was reactive, but the resident has a glass eye. So this is inconsistent, and it's also conflicting. And notes that look cloned cut or paste or falsified may be hard to defend. For example, the note says resident ambulating in hallway. The resident had a fall on the previous shift and is not ambulating currently. If that note was copy and pasted, it needed to be reviewed and edited before signing off. When documentation is inconsistent or there are discrepancies, it can call into question the entirety of the note and the history of the record for that resident. So here are some key red flags for documentation that may impact defensibility. I just mentioned charting inconsistencies, late entries or addendums that aren't labeled as such or appear to be self-serving. For example, you added an addendum weeks later after treatment for a fall that resulted in an injury. Treatment was delayed and impacted the resident's health outcome. Jousting between healthcare providers is a red flag. As I mentioned earlier, this is when two clinicians disagree in the health record or call one another out for an error or omitting care. Referencing an incident report or discussions with risk management or your legal team. This documentation will allow the incident report to be discoverable, but also makes it look like something occurred that would increase risk or liability. Alterations to the record, again, have that policy for late entries and addendums and reinforce it. And lastly, it's a red flag if records are missing or destroyed. This is an argument for spoliation or of evidence from the plaintiff's attorney. So let's put together everything so far and look at a note and see if you can spot the red flags. I'm going to read it because it's not that long. The entry time for the note is 4:35 p.m. The resident was found on floor in her room at 12:05 p.m. by CNA. Resident was assessed and reported pain in left arm. No increased pain with movement. No skin tears or bruising noted. No neurological change. Vital signs are there. Pain at 4 out of 10 in left elbow, but it does not appear fractured. Alert and oriented ×2. CNA left call bell out of reach. Physician notified. New order for acetaminophen, 650 milligrams by mouth every 4 hours for as-needed pain. We'll monitor for changes over 72 hours. An incident report was completed. Give you a few more seconds. Where are the red flags? What would you improve? Think about all the best practices. Is this accurate? Is this timely? Does it seem complete? So let's look at some of the pieces of the note. The note was written 4 hours after the fall occurred. So reflect back to the policy. When is it a timely note? A late entry or an addendum? If this is a late entry, it should follow that procedure. The policy should be applied consistently and all entries should be defined. Resident was found on floor in her room. Well, what's her room number? Where is her room? Where she was found? Where in her room was she found? In what position? Was there anything nearby that she may have hit her head on, perhaps? Was blood found at the scene? Resident was assessed and reported pain in left arm. No increased pain with movement, no skin tears or bruising noted, no neurological change. Was any of this different from her baseline? Which part of her arm does she have pain in? What does the neurological assessment find? Pain is at 4 out of 10 in left elbow, but it does not appear fractured. Does not appear fractured is subjective, and it's making an assumption. CNA left the call bell out of reach. This is jousting. It's you're calling on a team member. It doesn't provide necessary information. Physician notified new orders received for acetaminophen, 650 milligrams by mouth every 4 hours for pain as needed. We'll monitor for changes over 72 hours. Was the family notified? Which physician did you call? And what's their name? And who answered the call? And what changes are being monitored? and an incident report was completed. Incident reports should just not be referenced in a progress note. So here is a note for the same fall that, oopsie, that follows best practices. Any additional information that's not here can be included in the internal investigation. So this is one way to apply best practices for documentation. Resident noted on the floor of room 214 near the foot of the bed, lying on her left side, excuse me, discovered by CNA during routine rounds. Call bell on bedside table in corner of room. No lacerations, bruising, or contusion noted. No furniture or objects nearby. The environment was dry and free of hazards. Alert and oriented ×2 does not know the year, and this is consistent with her baseline. She complained of 4 out of 10 pain in the left elbow. She's guarding elbow. Neurochecks are within normal limits. Vital signs are stable. Dr. Rose was notified at 12:30 p.m. Orders received our portable elbow X-ray and as-needed pain medication. And the resident's son Henry was notified at 1 p.m. So a best practice note may look a little bit different from person to person, but this is just one way to apply it. And lastly, I just want to shout out to the nurses out there. We know you're providing the best care you can, the best care your system allows you to provide. It's important to understand that when documentation audits are conducted, it's not a measurement of clinical decision making and clinical prioritization of care across all residents. A nurse can have 20 residents to care for, and if one resident has a medical emergency, the care of the others could be impacted. Each resident's documentation cannot contain information about other residents, so the context of the nurse's workload is going to be missed completely. So nurses will also consciously prioritize resident convenience and satisfaction over documentation. So documentation may also take a backseat to customer service if necessary. So when you're auditing documentation, try to audit the entire resident care process, not just the documentation. Human error is due to system weakness. So when an error occurs, ask how the system design creates opportunities for error. The nurses should not feel like audits are pass or fail, and they must have feedback and be provided with support and education to improve. And education and training for adults should always incorporate adult learning principles. We learn differently than kids. We need to know why we are learning something or why we need to do something. We learn best through hands-on training. We learn best when we can immediately apply the training. It enhances retention. And we are natural problem solvers. So give examples and case studies, real incidents that you can apply best practices to problem solve. So make sure nurses understand why you are asking them to apply all of these documentation practices. It's a risk management approach. Good and defensible documentation protects the resident, it protects their license, and it protects the organization. And I'm going to throw it over to Tony.
All right, thanks. So I'll finish up some of our slides here, and we're covering our third objective to analyze some case examples and really just illustrate how fall response and really documentation can influence, liability. So I'll share with you a little bit about some litigation trends in senior living. Many of you may be aware, but falls make up over 40% of most closed claims in senior living. So that's looking at assisted living as well as skilled care. And according to the most recent CNA Aging Services report, the average cost of a fall claim was about $239,000. The same study found that assisted living communities actually had experiencing more falls at a higher cost. Next slide. Before I get to the nursing licenses, I'll just mention that there's a couple other insurance studies that have been done by Oliver Wyman, Marsh, WTW, and they're really all finding that, again, falls are the highest frequency when looking at claims year over year. So that's not changing. Um, so looking at nurses in particular, your licenses are at risk, and it's unfortunate, but nurses can be, personally named in litigation, which can be quite traumatic. So, according to the Nurses Services Organization, documentation deficiencies were, contributing factors in many of the nurse professional liability claims and state board nursing matters. So the average cost to hire an attorney to defend a nurse during a state board investigation increased by over 33% in the last 10 years. NSO says that the frequency and severity of these nursing malpractice claims are rising, looking at the last 3 studies, which they do every few years. Next slide. So I do want to run through just a couple cases that are real cases. You can find online more information about it, but I just provided a couple facts here. So this first case is happened in a New Jersey nursing home where a resident suffered a head and a hip injury after being noted on the floor. The plaintiff argued that the nursing home failed to implement reasonable fall prevention measures. Really, the key to the case was that there was an inadequate documentation. So without that proper documentation, you really can't substantiate your defense or demonstrate that proper care was provided. So the case settled for $275,000. Next slide. The second case here is an assisted living in South Carolina where a 100-year-old resident was on hospice while she was a resident at the community. There was an aide that was assisting the resident up from the commode when she fell. According to the documentation, the resident was put back to bed by the aide. Later, an hospice worker arrived and noticed that the resident had bruising and swelling around her knees, her lower thighs. The resident ended up having bilateral femur fractures. The resident went out to the hospital, unfortunately passed away the next day. So the plaintiff argued really that the employees did not want to protect the resident, that the staff failed to assess the resident post fall, that the resident's family was not informed purposefully, and there was inadequate staffing. And I can just pause there to let you think about, most people who work in senior living, right, are doing this because they care about people. So not wanting to protect the residents, it's not likely. But really, the documentation was lacking. It was not able to provide, facts that actual care was provided, after the resident had the fall. The case settled for actually $475,000. Next slide, please. This third case is a Wisconsin nursing home where a 93-year-old resident who had Parkinson's and dementia had a fall in the dining room. According to the information, there were 11 other residents present during the time that resident had a fall. So she sustained a subdural hematoma and a facial laceration. She died a few days later. So the resident's daughter pursued the lawsuit, and with the plaintiff attorney, they claimed that the facility failed to properly monitor the resident, her mother, failed to adequately train their staff, and failed to provide adequate staffing. So the incident was not documented well, nor was the post-fall assessment and follow-up. So the case settled for $200,000 in this case. Next slide, please. So this fourth case is where a resident in a Minnesota nursing home was admitted after a stroke and had a fall off the toilet. She sustained a brain bleed and died later. After the fall, the resident actually discharged to another nursing home where she experienced assault by another resident, which likely was the cause of the brain bleed. Uh, the argument of the plaintiff really focused on the fact that they thought the nursing home failed to adequately supervise the resident. It was stated that they failed to timely equip the resident with a physician-required helmet. They failed to ensure the employees were aware of her known risk of falls and failed to provide assistance while she was on the commode. Um, so again, documentation was lacking. This case settled for $300,000. And, you know, again, it's a tricky case, but it all boils down to the documentation. Um, we'll have the next slide, please. So I do want to talk about a particular case, which these are really hard to measure in terms of success, but this is really talking about a particular incident, which is real. It actually happened, um, and it did not become a lawsuit. So again, hard to measure if you did everything right and there was no repercussions. But I'll just talk through a little bit of it. Um, Illinois nursing home, there was a 78-year-old resident that had a diagnosis of right hip fracture with internal fixation, urinary urgency. She had CHF, hypertension. So her current meds included a blood thinner, two antihypertensives, a diuretic, and pain meds as needed. The resident originally fell in the community when she was walking her dog, where her foot got tangled in the leash. She ended up breaking her right hip, again in the community. After she discharged from the hospital, she came to the nursing home for rehab. Um, the skilled nursing facility, um, you know, staff found the resident lying or observed her lying on the floor in her room. So the nurse was quickly notified. The resident was noted kneeling near her bed on her left knee with her left forearm bleeding, and her right leg was extended straight in alignment with her body. The supportive documentation that we identified that was helpful and again preventing it from going towards a lawsuit included an initial fall risk assessment that was done timely, accurately. All sections were completed. To go along with that fall risk assessment, there was a follow up care plan in place prior to the nursing home fall, asking the resident to use her assistive device when ambulating. Therapy helped put that together along with the nursing staff. Excuse me. There was documentation regarding the resident and family education on multiple occasions from multiple staff, including the nurse, the physical therapist, the social worker. So documented how that person was educated, whether they understood the education. There was timely post-fall assessment completed. So after that resident fell in the nursing home, they did another post-fall risk assessment. They assessed the resident for pain, for injury. So the note mentioned that skin on the left knee was red with mild inflammation, no increased pain with movement or range of motion. The resident had full range of motions to her left lower extremity. There's a superficial skin tear to the left forearm, approximately 5 centimeters in length. Her vital signs were recorded in the record and were all within normal limit. The post-incident documentation included progress notes for timely notification of the physician with no new orders, and the family was notified as well, and it specified who, when they were spoken to, if a message was left. The incident investigation really included all the key components. One of the highlighting pieces of that was a resident statement with quotations used, showing the resident decided and chose not to use her assistive device, even though she knew she should have done so. The post-incident documentation was completed every shift for 72 hours. That documentation included resident assessment, pain, range of motion, vitals, all the key info. So again, it's hard to measure successful documentation, but this is just one example. I think we'll have some time now to go towards some questions. So please feel free at this time to submit any questions you might have in the chat feature, and we can go through those one by one. We thank you so much for kind of listening in, but happy to go through a few questions. Give y'all a moment to throw some in there if you're interested. Shannon, I will throw a question over to you. We had one come in that asks about your mentioning of the post-fall huddle. After the huddle document is completed, would you recommend scanning it and putting it in your medical record system or your EHR?
No, I would not from a risk management perspective. The post-fall huddle is a copy document, so it should just be included in your fall investigation documents and as part of your copy. It's a copy product, so make sure that you have that confidential language on the document.
Yeah, and I'll just add is, we really, and I think Shannon mentioned earlier in the presentation about, progress notes should not allude to or mention progress
Oh,
notes in your resident documentation. Okay.
you just froze for a second,
Oh,
but I think we heard you. You don't
okay.
want to
Sorry
mention
about
an
that.
incident. You don't want to mention an incident report in the progress note. Yeah.
That's correct. Sorry, all. Um, we did have another question come through. What would you suggest in terms of a time frame for late entries when you're thinking about a documentation policy, Shannon?
Good question. So again, we're not providing legal advice here, but from a risk management perspective, I think it could be anywhere from sometime after the shift where you know the incident occurred, um, and maybe up to 72 hours. I think up to 72 hours would probably be okay. But I think it's
Which would,
it's just a good here's a good opportunity, good reminder, to look at your policy and make sure the time frame's in there, that you feel comfortable with it and your staff are educated on that. They know what they have to do. They know the time frames.
yeah, that sounds great. A few people are asking in the Q&A here if we can receive the slides, and yes, we can send out the PowerPoint and slides along with our recording after the webinar. I'm happy to pass that along. Our contact info will include that on there if you have any follow-ups that we didn't get to. Um, looks like we had one other question come through. Someone is asking about the jousting and documentation and what's the best way to kind of teach your staff not to joust or not to, looks like throw them each other under the bus. What wouldn't you have to say about that, Shannon?
I would say just constant education and modeling with the same consistent messaging is going to be the key there. Educate staff that the medical record is left for objective information, information that's crucial, that's beneficial to the quality of care for the resident, and being mindful of all information and what each piece of documentation is providing. So does it have a place in the record? What does it do for the resident or the provider? Learning about the resident or their condition in the record. Medical records not a place to vent. And internal channels, should hopefully be there to support that if needed. And the documentation should be reviewed and asked, ask yourself if it's relevant to the situation at hand. And if it's not relevant, if it's not vital, then maybe it doesn't belong. I think I mentioned that emotional response. If you find yourself putting an emotional response in the note, then it's probably not as objective as you think it is.
Makes a lot of sense. Okay. Think we've answered most of the questions here that have been submitted. As a reminder, we will send out the slides, we will send out our recording at the conclusion. And please expect, again, a short questionnaire for feedback. If there are other topics you're interested in hearing more about in the future. We really appreciate everybody, your time today and dialing in, and we look forward to connecting with you all in the future.
I just want to say if any of our clients have questions or want a copy of our post-fall huddle tool, you can reach out to Tony or me. And when we visit your facilities, we will ask you some questions about your documentation practices and ensure that you have a policy for your documentation if it follows best practices. So we look forward to those conversations. And we're always happy to provide more education on documentation if you feel like you need it at the corporate level, organizational level, staff level, whatever you need, please reach out.
Absolutely. Agreed. Thank you so much, everybody, and everybody have a great rest of the afternoon.
Thanks, everybody.